I've also been reading blood labs since 2017, and we have put together the course for you on nutritional systems on how to read blood work. Of course, that course is an 8-hour course, and there's a lot more to the subject. So these webinars are expanding on that. But our main goal really is we just want to help practitioners get started doing blood work. It revolutionized our practice, just completely took all of the stress, almost all of the stress out of practice, much of it, like maybe 90% of it, which is pretty darn good. I was going to put a slide in here about how it affected our income, and I just didn't get to that, but it really helped. It really helped.
Well, our income went up 20% and we were able to cut our staff in half.
Yeah.
So our net income went up, what, 5 times?
Yes.
500%. Yeah.
Yes. So it's definitely worth it.
And our
And
results were better.
our results are better.
Bottom line.
Yeah. All right. So we want to introduce how to use lab tests, and then I'm going to let Keith here get into the nuts and bolts of the presentation. The purpose of the study group: we want to provide blood chemistry and other lab testing education for your holistic and natural health practice. We want other people to enjoy the success and practice that we have been able to create for ourselves. We want to make lab test data easy to utilize, especially for practitioners who also muscle test. We like to tailor to our audience, and we started out as muscle testing practitioners, nutrition response testing practitioners, and when we added the blood testing piece, it just made everything go so much easier. And then the other thing about lab tests is there's so much. Where do you start? That's another one of our goals, is to help you know what to do first, second, third, etc. So you can just use the information instead of not being able to use it. We want to connect you with lab testing solutions and then provide individualized support. We love to provide support for our team or our friends. We like to use our nutritional blood chemistry study group as one way of doing that, and then these webinars also. Okay, I want to go over cash-based labs. Why should you use cash-based labs? There's many wonderful reasons to use cash-based labs. Number one is the cost. You will not find a better price anywhere than with Avexia, who's our lab testing partner. Sometimes the price is actually 10% or less of retail. I find that amazing. Like, so if you were to go to the hospital laboratory and just pay out of your pocket, your fee would easily be 10 times more. Patients can use their HSA. Patients can self-file. Patients have high deductibles already. Jen at our front desk tells me all the time. Patients say, oh yeah, I know my insurance doesn't cover this already. So they know that their deductible's high and that it probably won't be covered. The other nice part is there's no back billing. So it's not like the insurance company can come back and say, oh, well, you still owe this and this because of our dumb fee schedule. You're working with an already incredibly discounted fee schedule. And then, of course, if the patient has any privacy concerns, it's always better to have fewer people's hands in the mix, like insurance.
Yeah. And you've had people say that they got back billed
Yes,
thousands of dollars.
that has happened.
And that's horrible.
It's kind of like a nightmare situation. Okay, so you don't want that. If patients just pay the extreme discount at your office, then they won't have
There's
to worry
another
about it
benefit
later.
I should note,
Yes,
mention.
tell us.
Um,
Here, this is Keith. Here, he's right here.
Hey guys. So one of the other things that happened repetitively. So what happened when I started doing muscle testing with AK in 1994, started specializing in, first it was contact reflex analysis in 1998, and then switched to nutrition response testing in 2000, then learned, NET. I learned a bunch of different techniques along the way. And what happened is patients more and more saw me as their general health practitioner, so they bring me in their labs. But what was happening was these labs stunk. They weren't complete. And on top of it, they were bringing them from their doctor. And so their doctor was between me and them. And we hear this repetitively, that when that happens, their doctor will just go against what we say. If I tell them this is the way to be healthier, eat right and exercise, they'll tell them no. We literally had this happen. A person dropped his triglycerides 2,000 points. That is not a typo, 2,000. He dropped his cholesterol almost 500 points. He reversed severe diabetes and Hashimoto's, and the doctor said, do not do what this doctor just told you to do, even though the medical doctor missed all of that. And I'm not saying you want to go against them, but the thing is, these doctors, they don't know how to run functional labs. And if you let them be in charge, they can really mislead people. I mean, right now, a lot of what they're doing is insurance. I hope I don't cancel for saying this stuff, but they give insurance-based answers instead of what's best for the patient. A lot of people come in and they say, well, I know my doctor doesn't have the education, and lack of education is not an excuse anymore. It's just not an excuse.
Yeah.
So what it does is it puts you back in the driver's seat for good. You want to be there for good. In other words, for the good of the patient. You can offer them solutions to their problems at a cheaper rate, and you can basically do the research for them. I don't know how many people come in and they go, what about this drug? And I actually just list the side effects, and they're like, my doctor didn't tell me any of this. Or I teach them about insulin resistance or Hashimoto's or methylation or whatever. And they're like, why doesn't my doctor teach? And I'm like, we used to take insurance, and I mean, insurance just takes over everything, all your time and energy. And it's like, this is an alternative system so that you're in charge, and then you can put the patient in charge. All right. By the way, it says that this is Adrenopause by Dr. Sheehan. All right. All I'm doing is presenting it. Laura and Jen put all this together just to give them credit, just to let you know. I just make sure that I give credit where credit is due. So anyway, anything else?
Yeah, it's nice when finally your patient CEO is the authority.
Well, and the thing is that I know doctors, I've talked to them, they're like, you mean you can reverse diabetes with diet? I'm like, they didn't teach you this? It's right there in Mosby's. It's right there on the American Diabetes Association website. We take our information from there.
Yeah.
And it's just being glossed over because it's insurance and drugs and surgery right across the board.
Yeah.
Anyway.
Yeah.
As one doctor told me, I don't tell them about diet because no one wants to change their diet. That is false. The patients that come in want to know about diet. They don't know because they're confused.
Right. All right. So I'm just going to try to do this fast. Avexia is our lab testing partner. We highly recommend that you sign up through Avexia to order lab tests. And here are some benefits to doing this. You can have access to all of the custom lab panels that we have put together, all of the lab testing panels that we teach. They have free marketing materials. And then if you do sign up through Avexia, that will help us to be able to continue to offer these resources for free.
Yeah.
And that's our goal. We really just love talking about this. We want to share this information. Signing up for Avexia will help us to do that. And here's how you do it. Let me just see. You can go ahead and scan that. That will take you to our landing page.
Okay.
Next. And now for our topic, Adrenopause. Hold on. Let me set this up for you.
Was right there?
Yep.
Okay. Cool. All right. Well, thank you for joining us. Okay. All right, guys. Well, good morning. Thank you for joining us for our topic of Adrenopause. How did we get to this topic? So when we polled practitioners about what they wanted to know more about, they said that they wanted to know more about hormones. And if you do the research on this, you will find that Adrenopause is a huge thing. All right, so there's a lot of questions about hormones, and there's a lot of tests out there about hormones. And, when you do the salivary tests, the adrenal stress index, you do the cycling female hormonal panel. When you do the Dutch test, when you do the blood tests, and you do a fair number of them, we don't do a huge number of them because we do a lot based on the nutritional blood chemistry course that we teach. And that kind of comes first. If you look at it, everything comes back to blood chemistry. But people have questions about hormones, and if you don't answer them, they're going to get them from, I guess, I don't know what it is now, Dr. Instagram, Dr. Google, whatever. And they can get some good information. They can also get some bad information. And when I looked at it and we correlated this with muscle testing, that's the reason why we ask people muscle test. We found that the adrenals are a very hidden link, and they're not hidden if you look. And it's very easy and very cheap to look, and it makes you look like a genius. And there's specific ways that we test. I mean, I didn't make any of this up. It's just stuff that I took because I've studied for the past 30 something years. And I kind of catalog everything that I've learned in here that is of importance. And so what we found was that adrenopause was a big, big thing. So that's kind of like the first hormone, maybe even more important than that is actually insulin. And that's in the NBChem beginner course that we have about insulin resistance. We teach all about that and how to assess it real easy. You can sign up for that course through UNS, ULM Nutritional Systems. Or you can just look back at any of the courses that we've taught for standard process. Or you could look at the course that I taught for PCA, Pennsylvania Chiropractic Association. But anyway, after that would probably be the adrenals. Okay. So adrenopause is an age-related decline of adrenal function affecting adrenal hormone production of DHEAS, pregnenolone, and this leads to decline in other sex hormones, key, progesterone, estrogen, and testosterone. Aldosterone, a mineralocorticoid, does not wane in andropause along with adrenal androgens, aka sex hormones. Cortisol, a glucocorticoid, also does not wane and in fact tends to raise with our age. So we get worse as we age, or at least we feel it. Another point that we didn't put in the slide, and I should probably say, is that as cortisol goes up, guess what happens? It actually suppresses thyroid function, so you develop more thyroid issues, thyroid symptoms. If you have Hashimoto's hypothyroidism, I guess possibly hyperthyroidism, stuff like that. So it's a big, big, big problem. The adrenals should really be part of the mix. And one of the reasons why we wanted to teach this little course is that we kind of want to put a little bit of extra stress on them when we test, because when people come into your office, hopefully they are not stressed out by your presence. Hopefully you have a nice calming presence, and you have a calming presence in your office. And that actually causes the adrenals to kind of like relax a little bit. You lay them down, you put them into parasympathetic mode, and next thing you know, the person doesn't show up as hyperadrenal, okay, or adrenal burnout or adrenopause or whatever like that. And so we want to stress them out just mildly. Don't say bad things to them, just put a little bit of stress. Okay, so this is really important. This is the adrenal hormone production over lifespan. And take a look at that. It tends to go up. Anyway, this is the adrenal hormone production over our lifespan. So you can see that it goes up and it kind of peaks roughly around 30 and it starts to go down afterwards. Incidentally, when we do our tests, kind of specialized muscle tests, not very specialized, but you see they're real easy. For adrenal function, yes, you don't see them tend to show up in people under 30 as much, and you definitely see it show up after 30, and for almost everybody after 30. By the way, I can tell you as a little thing here, not only did we get better results when we started addressing the adrenals, but in this past year, we really started focusing on this, but we got better results, and our amount of Adrenochrome we sold went up 400% last year. That's incredible. Our patient visits didn't really go up that much. Our patient visit over time, our patient visits don't really go up. We don't have to work harder. We actually have to see patients less. We make more money and we get better results the further along in practice we go. Okay, so who's affected? Adrenopause is a universal process that affects all with aging, but varies in impact. Key groups: older adults, post 50, well, I would say post 30, but definitely post 50, you really start feeling it. A sharp DHEA and pregnenolone drop. Muscle testing shows that adrenopause starts in the 30s with greater need for adrenal support showing up in the beginning with this age group. Men and women, equal adrenal reliance. Women post-menopause are more affected because sex hormone production shifts from the ovaries to the adrenals. This is very, very important. When a woman goes through menopause, then the hormonal production shifts from the ovaries to the adrenals. If the adrenals are already in adrenopause and they're under adrenal stress, your body, in its infinite wisdom, will put on 10 to 15 pounds of fat because that will help with some of the hormonal production, especially the estrogens. And so I explain this to people, as to women. Men too, we tend to put on a little bit of fat. But I explain this to women because they think that they have to diet harder and they have to do this. That's the exact opposite, because that increases cortisol. It makes the problem worse. I don't say that you ignore the problem, but you learn what the problem is. And the problem is that those adrenals are stressed out. Okay. I'm going to give you a couple case studies at the end, a bunch of case studies. I'm not saying that, boom, you're going to do this and all of a sudden you drop that 10 to 15 pounds. But if you explain it to a patient that it's actually their body's effort to be healthy again, and the fact is that usually the more that people beat up their adrenals during their lifetime, the more of a problem they have, they understand. Understanding tends to really help with people. Okay. Chronic stress, the hypothalamus, the HPA T axis overdrive depletes pregnenolone, DHEA faster. Remember, this is hypothalamus, pituitary, adrenal, and thyroid axis. Poor lifestyle, sedentary, nutrient-dense, standard American diet, sleep deprived, amplify the effects. I will tell you the biggest thing that I have seen that really jacks up inflammation and cortisol is the standard American diet. People say, oh, they're stressed for this and this. I can tell you in practice, and you run these blood tests and you run cortisols and you look at their sodium potassium ratios and everything, it's definitely junk food. And the only problem is we have a lot of misinformation. When we read the label junk food is good for you, that's really bad. Adrenal cortical hormones manufactured in the adrenal cortex, all derived from cholesterol. A lot of people that have these autoimmune diseases or have adrenal stress as they age will up their cholesterol in an effort to make more sex hormones and help with their age-related decline in their hormones. Okay. I'm not saying, okay, we should all jack up our cholesterol, but just realize that this is important. These cholesterol-lowering medications, can they fuel this adrenopause and sex hormone depletion? Absolutely. Just remember that. If you go, I want to think like the body, it will give you a lot of answers as to why it is doing things. I have found universally the body is not wrong in making a mistake. We just do not understand it. Okay, and here are some of the pathways here. Up on this upper left-hand corner would be cholesterol, which is turned into pregnenolone, and then more pregnenolone, 17-OH pregnenolone, into DHEA and DHEAS. DHEA turns into androstenedione, which is a precursor to testosterone and estrogens. And then you can also have pregnenolone go into progesterone. And if you're under a lot of stress, it goes into cortisol. Okay. The preferential pathway under stress shunts pregnenolone into cortisol at the expense of DHEA. So instead of going to the right, it goes down. This is the reason why you have to handle adrenopause and understand it. Okay. This is called pregnenolone steal. Sex hormone production suffers from the double whammy of both aging, adrenopause, and stress. And what's the number one stress? I just told you. It is junk food. Let's go over the pregnenolone steal again. People used to always talk about the pregnenolone steal, and I'm like, what is the pregnenolone steal? The reason why we put these together is because people reference these things, and I'm like, well, is there black and white? Like, is it there? Yeah, it's there. You just got to put it up on screen. So the pregnenolone steal, look at stress. Look what it does to the HPA axis, the poor HPA axis. It takes pregnenolone, cholesterol turns into pregnenolone, and goes, I want to make cortisol for more stress and cut down my sex hormones. Oh, it really sucks. So stress in the HPA axis dysfunction causes pregnenolone to prefer a cortisol pathway, thus stealing from the androgen pathway. The result? Sex hormones are depressed. And remember, by the way, those androgens are turned into estrogens, okay? And we'll see some case studies where guys were saying, I want to up my testosterone. Instead, they were upping their estrogens. So anyway, the result, sex hormones are depressed. Cholesterol production can be increased to fuel pregnenolone production. We notice this as we age. Cholesterol goes up, and the doctor says, your body must be making a mistake. Here is a statin. They don't say, why is this happening? I mean, if you look at it, cholesterol ingestion affects what, 20% of your total cholesterol, whereas production is 80%. You want to know why it's happening. Cholesterol is not bad, but you want to know why it's happening. It's more like saying, well, why is this going up? And if you see it's going up just because you're aging, I mean, would you really want to decrease it? I mean, your body's not stupid. Okay, the HPA axis connection. What is it? The hypothalamus pituitary adrenal thyroid axis regulates stress and hormones. Think brain. Chronic stress, overactive HPA thyroid axis depletes pregnenolone and DHEA. Sleep, diet, toxins disrupt the HPA-T axis rhythm and adrenal reserves. Aging blunts feedback, skews cortisol over pregnenolone and DHEA. Infections and or inflammation. Okay, that's what we cover in the first 3 or 4 steps in nutritional blood chemistry, which is basically food sensitivities, a big source of chronic inflammation. And then it goes into digestion, insulin resistance, and inflammation and infection. So infections and inflammation can also suppress the HPA-T axis, a double axis there, that's a typo. But anyway, reducing overall hormone output. Refined carbohydrates are the most common cause of elevated sodium, cortisol, and hyperadrenia, in my observation. Chronic stress and chronic immune are the most common cause of elevated potassium, depressed sodium, and functional hypoadrenia. So this is important, and we go over this in the beginner course of nutritional blood chemistry, is that when you see sodium go up and potassium go down, you're looking at like hypercortisol production and chronic stress. So looking at hyperadrenia. That's most likely caused by the first 3 things, which are going to be food sensitivities, problems with digestion, especially insulin resistance and infection. Not as much infections, actually, but those first 2 really. And then if you see elevated potassium, that's more like chronic hypoadrenia. Okay, and that's usually from what I've seen from chronic stress and chronic immune system stress. Symptoms: fatigue, flattened cortisol rhythm, reduced libido, less DHEA and pregnenolone for sex hormones, muscle weakness, declining anabolic support, mood changes, irritability, depression from low pregnenolone neurosteroids. This is also really important. You know, pregnenolone, progesterone are neurosteroids. Steroids get a bad rap, but they are anti-inflammatory towards your brain. You don't want to leave this unhandled. Poor stress resilience, HPA-T axis adrenal capacity, cognitive decline, brain fog, low pregnenolone, bone density loss, and skin hair issues from hormonal shifts. Really important stuff. If you look, this looks exactly when people say, oh, my hormones are changing. I must need more testosterone, estrogen, and progesterone. Yes, possibly. But if you look at the precursor of that, that is going to be pregnenolone and DHEA, which is more adrenal. So why aren't we handling the adrenals first? By the way, my little conspiracy theory is the reason why we're not handling this first is because all the stuff that you use to handle your adrenals are over the counter. The other things, testosterone, estrogen, progesterone, you can get estrogen and progesterone over the counter, but testosterone you can't. And so it's becoming easier. But it's like you're seeing that basically they go towards what there's restriction. Anyway, that's my little conspiracy theory. Important nutrients for sex hormone synthesis. You've got cholesterol to pregnenolone, and look what it needs. It needs vitamin C, magnesium, and iron. By the way, never give iron without checking their blood test. A lot of people think that they have low iron, actually have high iron. Usually I actually call it an iron imbalance. Iron goes to the wrong place a lot of times. People say, is it high or low? That is not the way to think about it. You say, why is it going to the wrong place? But vitamin C and magnesium for cholesterol, pregnenolone. Pregnenolone is turned into progesterone, then cortisone and aldosterone. Also use vitamin C, iron, zinc, and magnesium. Then pregnenolone to DHEA and testosterone, estradiol, vitamin B6, zinc, iron, magnesium. Notice these are all coming from the same thing. That's why we use standard process a lot. And spoiler alert, we use a ton of Adrenalin. We use some magnesium. If someone actually does need iron, if they have an iron imbalance and they need it, they have low ferritin and they're anemic, then you give ferrofood. But you can also give, what do they call the zinc now? Zinc complex or zinc chelate?
Zinc complex.
Yeah. General support is vitamin B5, vitamin E, copper, and selenium. All right. Do you have any questions? Were you talking about dietary cholesterol? Well, actually, that's a good point. Cholesterol is the cholesterol on your blood test, and most of the dietary cholesterol does not contribute to your blood level cholesterol. Blood level cholesterol is what you make. We're going to put together a course on that. Cholesterol is a multifaceted topic. Usually, what we see is that there is a certain tendency. I'll tell you my little story about this. So, my grandfather had 7 heart attacks. Yes, he drank too much and he smoked and he had rheumatic fever, but he had 7 heart attacks, I think, starting at 50, he died at 64. My father was scared to death that he was going to have a heart attack. So they put him on blood pressure and cholesterol meds very early. I think my brother went on cholesterol meds and my mother was on cholesterol meds. So I asked, I'm not adopted. When I was 21 and I first got sick, the doctor said, you're already showing that you've got low HDL and your LDLs are going up. My cholesterol wasn't high, but he's like, you're going to have to go on an extreme low fat diet and a high carbohydrate diet. Well, then I got really sick. And I read some into biochemistry and I was like, that doesn't make sense. It seems like basically if you eat a lot of carbohydrates, they can be turned into cholesterol. So I went on the zone diet, and I'm giving you Reader's Digest version. And I was on a college budget, so I ate ground chuck, tuna, chicken, turkey, about a dozen eggs every day. I would eat 6 to 8 times a day. So I was eating massive amounts. Yeah, I know it was awesome, right? And I ate a lot of fruit, by the way. So each meal I would have about 4 to 6 ounces of protein with lots of fat, extra nuts, and then I would have 2 to 3 pieces of fruit. Yes, I went through a bag of fruit a day, and I went through about 2 to 3 pounds of meat per day. And what was very interesting was I felt so much better. I said, my grandfather died at 64 and I was 20. At this point, I was like 24. I suffered with chronic pain, like debilitating, crippling pain. And it got better like within a couple of days of starting this diet. And I said, I feel so much better. If I have to die by 50 following this diet, because cholesterol kills everybody, remember? Well, I'm going to die by 50. I'd rather feel good for the next 20 years or whatever it was, than feel like garbage like I had. Life was really that bad. And I got my cholesterol taken and it dropped down to 129. And I was like, oh my gosh. And I was like, oh, Dr. Sears from the Zone, he was right. It's biochemistry. And so I found out that sometimes your cholesterol will be, by the way, I don't take any cholesterol meds still. I don't have high blood pressure or anything like that. Do I still eat a ton of fat? Oh yeah. I don't eat as much that I'm just not as hungry. I only eat like 3 or 4 times a day. But what I found, one of the things that will raise cholesterol is family. But people, they misunderstand things. They think if it runs in my family, it must be genetic. Well, after taking classes on genetics, it's not. It's mostly lifestyle. We actually go with the same lifestyle. I changed my lifestyle from my family's lifestyle when I was 24, and that's what dropped my cholesterol. Okay. There's a couple other things that tend to raise cholesterol. So there is genetics, it's diet, basically junk food. Chronic thyroid problems, that's a big problem, and they're not totally underdiagnosed, but misunderstood in our society, and we can teach a course on that and why. Also, autoimmune and inflammation, because that will actually raise cholesterol, because cholesterol is actually an antioxidant. That's one of its purposes. It is not just something that kills you. So, yeah, very commonly missed thyroid and autoimmune impact. That's one of the keys. When I see somebody that comes in and they do not have insulin resistance, they have high cholesterol, and I see that they only ran a TSH, I'm like, I want to see the rest of those thyroid hormones. And I'm like, did anybody run thyroid antibodies? And the patient will be like, what are those? And I'll be like, because one in what was it, 12% or 13% of people have those positive thyroid antibodies and are not addressed. That's a whole nother course that we can teach about thyroid. It's very, very important. So I educate the person. I also say, we now have AI, and before it kills us all, you can ask about cholesterol. You can look at it all. By the way, that person that reversed his diabetes, he had an HA1C of 12.1. He handled his Hashimoto's. He reversed his insulin resistance, and he dropped his triglycerides 2,000 points. What did he eat? Meat and eggs and a little bit of vegetable. And he's like, I did my research. He's not a stupid young man. And he's like, this is obviously what's going to work. And it did. So anyway, so good question. So, all right. Well, if there's no other questions, we will proceed. So how do we handle adrenopause? Symptoms and muscle testing. I was taught that blood testing doesn't show anything. That is false. If you know how to read them, blood testing shows a lot. Okay, keep in mind a little segue that the reason why there's a half-truth in that blood testing doesn't show anything. The thing is, if you look at standard lab reference ranges, that's basically just a population that's going in to get their blood tested. You have sick people and healthy people. Most of the time, the people are getting their blood tested, and the average population are people that are already sick. So you're going to have skewed towards a wider range. And so Dr. Dickon Weatherby took 20,000 healthy people that weren't overweight, they didn't have blood pressure problems, some other things, and he said, what is their range? And that's called the functional range. By the way, I'm not friends with Dickon. I mean, he sounds like a nice guy, but I don't get anything from being associated with him or anything. It's just that we base a lot of our ranges on what he said and some other things that we found out when we have to do our own research. Okay, so that's the functional range. So when you look at the functional range is usually inside the standard lab reference range. Okay, so that's what we use. So blood testing shows a lot, especially if you understand biochemistry. If you're looking for it for just pathology, if you say, you know what, the body does not work in a biochemical method, we just look for pathology, yeah, you're not going to show much in most of your patients. But you've got to run blood tests for this. The other thing too, that if you run blood tests, you're communicating in their language, the patient's and the doctor's language. They cannot argue with you. We had a person that came in, he was arguing with me about his blood test, and his daughter started cursing at him, said, these are your blood tests. These aren't doctors' blood tests. So anybody that argues with blood tests, that's not someone who you want to argue with because they're not using rational thinking. But symptoms and muscle testing, we use a lot of that. What's really cool about looking at symptoms and muscle testing is you don't need a blood test. The thing is, you can't run blood tests on every visit. You do want to have regular checkups with them, but you don't run them on every visit. That's what makes what we do really, really effective. We use all three. Okay, and laboratory testing for adrenopause. So I'm just going to bottom line it. People say, why don't you use salivary testing and urine testing? Because blood testing is the gold standard. And whatever you see on salivary testing and urine testing, you're going to go back to blood testing and say, usually the problem with any kind of adrenal hormone skew is going to be like, well, do they have food sensitivities? Do they have problems with digestion? Do they have insulin resistance? And do they have a chronic infection? You can find a lot of that with muscle testing, but you should also run the blood test so that it makes it real to the patient. If you muscle test something and you say, hey, you've got a real problem with gluten, and you do not show them on a blood test, they're going to say, yes, I cut out gluten. And then shortly afterwards, after they feel a little better, they'll put it back in there. And since they're addicted to it, they won't tell you. And then you're wondering why they're not feeling better. That happened a lot to me. Anyway, but there are other ones, and we do run them if we want take a closer look at hormones. But these are the different tests. We use the Sheehan standard panel for all of our new patients. Yes, even kids, unless they're like really, really tiny. And then we use like a child's panel if they're under 30 pounds, something like that, 35 pounds. But we use a Sheehan standard panel for everybody. And that shows everything from electrolytes, insulin sensitivity. It shows some of the most important cardiovascular risk factors, some of the food sensitivities, immune function, all that kind of stuff. And the pros about doing just the blood testing can identify the other areas that affect the HPA axis. The thing is, if you say, okay, I'm going to run this Dutch test and it's going to be $300, I'm going to have a markup for reading it, and then you're going to have to come in and you're going to say, okay, now we got to run blood test. It sounds like a little bit of bait and switch to me. So anyway, that's why we run the blood test first. The cons about doing blood tests: blood draw means needle stick. You also have to learn to read them. The reason why we put together the beginner course for UNS was I was like, if someone actually showed me from beginning to end, I would have been able to do it instead of just like, these are what the blood tests mean. That's what we go over, is how to order them, then basically how to put them into the initial visit, the report, and then you do the follow-ups. That's actually the most important thing with blood tests. So anyway, diagnostics with the adrenal stress index and the other hormones. The saliva sample collection, it's easy, fast, and no blood draw. The only problem is that it only provides data on hormones. Blood testing provides a more comprehensive view, another learning curve to interpret. The other thing too is that when you do salivary hormones, it's like there's mountains of information on blood tests. There might be mountains of information on salivary tests, but then basically you're saying, okay, we're going to do something different than it's accepted by 99% of the population. Right there, we might use them. They might be helpful to us, but you're kind of miscommunicating with the patient. And the Dutch Complete, I love it. It gives a lot of information. Detailed look at biochemical pathways, urine sample, no blood draw. It's expensive. You still need to do the blood test, and tends to show what we already. Laura goes, whenever I find something on the urine test, I'm like, the heck, man, this thing's really complicated. What does this mean? And she goes, well, you have to find the information. I was like, why don't we just do that on the blood test? She's like, yeah. So that's the reason why. Okay, this is very important. Screenshot this. Keep it. Very, very important. Laura found the research on, you found the research on this, right? You did this. Where'd you get this from?
I got it from the nutritional doctors from the 80s who put it.
Oh, yeah.
Most of these
We have the books from the 80s.
ranges
And I read them. It's light reading. No, it's not. By the way, it has totally been changed from the 80s. If you look at the blood labs and stuff like that, like, I will give you just a piece of information. They refer to TSH all the time as a brain hormone, not a thyroid hormone. TSH is produced in the brain. They also say that to assess thyroid function, use T3 uptake, not TSH. Interesting. But yeah, Laura got it from one of the beginning functional blood test books from 1988. I don't remember the name. Laura might have it over there. Anyway, so look at these ranges. These are very, very important. Oh, here it is.
Clinical Chemistry and Nutrition Guidebook
There it is.
by Jaffe and Yannick.
Yeah. Anyway, so that's it. That's where we got these from. What is the best cortisol test to take? Morning cortisol. That's usually what we do. From what I've seen, that's the most important one. It'll show up. Yep. I think one of the good things about doing salivary tests is that'll give you a rhythm. You can take a number of tests during a day. If you're a cycling female, they'll tell you what's going on per month. That is a very big bonus to those. And the Dutch test, actually, remember the Dutch test tests urine. It doesn't test salivary for free hormones, and it does not test active hormone. It tests metabolites, so how you're metabolizing. So that's important to know too. Saliva through diagnostics. Okay, so screenshot that. By the way, on the Nutritional Blood Chemistry, the beginning course that we teach for UNS, we only cover sodium potassium. And it is affected by adrenal hormones, primarily aldosterone. But here's the key that we're seeing when you actually start looking up drug interactions. A lot of the people that come in here that have adrenal stress, especially the worst ones, the worst cases are pre-diabetic or diabetic, which is what, 2/3, 90% of the population now, something like that. 2/3, depending on who you talk to. A lot of times they'll be on medication. Their medications alter their sodium potassium. That's why you want to run one of those other labs that we recommend. It's very, very important. We found that out. I'm like I have a patient right now, and she's on, oh, poor woman. She was put on one of those GLP agonists, and then she was on diabetes meds, I think two diabetes meds, laxative, all sorts of things. And she had greatly disturbed magnesium, sodium, potassium. And I looked, I'm like, these meds are doing it on top of the diabetes. So it's like, that's when it dawned on me. A lot of people that come in, you can't rely on sodium, potassium levels anymore because of the fact that they're on drugs. Okay, the other thing too is I have heard many times from patients, if they are low in sodium, their doctor will say, you need to consume more sodium. I don't know if that's true. I can tell you that they definitely have an adrenal problem, and you should probably fix that because that does help. Okay, but remember, sodium potassium levels are dictated by the adrenal hormones, not as much by what you eat. Anyway, all right. So, Adrenopause nutritional assessment. If you're doing nutrition response testing, awesome. Like I said, that's the primary thing that we do. We added a couple little steps to put people in a little bit of stress at the beginning of the exam so that we could get better results quicker on less supplements. And that's why we added these things. It's called the whole body pulse. This is like when you pulse an arm. We've got the master point. Remember this in UNS? The general adaptation syndrome. Okay, there's a test for that. Postural test when you go from lying down to standing up, like Ragland's test, named after Dr. Ragland. And test and go with the adrenals. And you can do Ragland's test. So let's go over them. So this is the whole body pulse, or when you pulse the arm. Okay. So the pulse definition: any throbbing characterized by a short, quick, and regular stroke or motion and pulsation. That's Funk and Wagnalls. Okay. Instructions: test for lock of the indicator muscle and test how many times you can do this before the muscle unlocks and goes weak. The optimal pulse is 10. If the number is less than 10 or even 0, test Adrenochrome, Cardio Plus, water, stressors, and the body scan. Okay. That is the first step that you do. The way that we were taught is you skip the first 3 steps and you go right to stressors. We have found so many people, including myself, I could not get better. When we found out that I was in severe adrenal depletion, basically we put Adrenochrome on me and boom, all of a sudden I went strong and I got better. Real, real important. Okay. All right. That's the first thing. That's the whole body pulse. The second is the master point. The master point is located on the bridge of the nose. Muscle testing the indicator muscle while touching this point with the pad of the index finger and then the nail side. If the indicator muscle does not unlock one side, test the following: Adrenochrome, Cardio Plus, water, stressors, and the body scan. By the way, so this is how you do it. Put it here and there. If the person doesn't go weak, you put Adrenochrome on their body. If it goes weak, they need Adrenochrome. Okay. If Adrenochrome doesn't work, you put Cardio Plus in the body. If it goes weak, they need Cardio Plus. If that doesn't work, what you do is you can put water on the body. They need water. If that doesn't work, you use the UNS test kits to test for stressors. And if that doesn't work, you keep the finger there while you do a body scan to see what is basically blocking their master point. So this is a little segue. I want to tell you a little something here. So if you look at the ingredients in Adrenochrome, Adrenochrome is what? It's cataplex C, cataplex G, and adrenotrophin. What is Cardio Plus? Cardio Plus is cataplex C, cataplex G, cataplex E2, and cardiotrophin. Notice they are very similar. They test very similar. I have found a little segue. I would say 80% of people with this thing where you have trouble with the master point are going to come up with Adrenochrome or Cardio Plus. I would say more with Adrenochrome, okay, adrenal, than Cardio Plus. But the ones with Cardio Plus, I started asking people, do you have either your mother or father that died of heart disease? And I would say 90% of them said yes. And I started referring to this as the genetic heart test because there probably is something genetic there. And I'm like, okay, I let them make that connection. Hey, he asked about my ancestry, and here basically there's something for it. And I just tell them, if something happens and I'm not around, you move away, whatever, don't stop taking Cardio Plus. There was a reason why Dr. Lee made that. By the way, when we did these first two steps, that's when our sales for Adrenalin went up 400%. Probably Cardio Plus went up too. So, okay. Here's the next one. This is not a good picture of it. It's hard to put in a picture, but if you remember from Hans Selye, he talked about the general adaptation syndrome. You stretch the ligaments of the wrist with moderate force by placing one hand on the patient's hand and the other one just proximal wrist joint. Give the wrist a few assertive tugs. You go like that. Okay. When you stress a joint, you are stressing the GAS as per Hans Selye. There are other ways to do this, just to let you know that we do not go over just because this is like real easy. You can stomp your foot. You can also shine up light in a person's eye. Those are some of the other ways. It's real easy just to go like this. People will say, what are you doing? And I'll tell the person, I'm putting a little bit of stress on your body and see if it works or if you fail. Then immediately test the indicator muscle. If it goes weak, test for adrenal support. Once again, usually I never test for Cardio Plus with this because I would say it almost always goes strong with Adrenalin. But you've got Adrenalin, adrenal desiccated, adrenal complex, and adrenal tone from energetic sometimes. Okay. So, Adrenopause, position of fatigue. Hey, there is a genius way of doing it. What happened was I was like, why isn't this showing up? How many people say, oh, I stand up and I get dizzy? Basically, instantaneously, within milliseconds, when you stand up, your adrenals, they produce, what is it, adrenaline? I think it's adrenaline. I might be a little bit wrong, but basically to jack up your blood pressure so that when you stand up, you don't pass out. So what you do is you go from lying down to standing up. Okay, that's it. Just like Ragland did, just like Dr. Ragland did. You know, apply kinesiology. That's why they call it that. Test the whole body pulse in position that is most stressful as your patient, or just after changing positions. If the indicator muscle goes weak, test adrenal supplements to strengthen. So you have the patient has a whole body pulse of 10 when lying down, but after going from lying to standing, their whole body goes to a 0. So you go through the same thing. Adrenaline, desiccated adrenal, adrenal complex, energetics was adrenal tone. Okay. So you can also punch somebody in the kidneys. No, don't do that. That would be kind of like goading. That'd be aggressive goading. Don't do that. The adrenal reflex are located in the back bilaterally at about level T8. To goad an organ, rub it lightly for a few seconds to bring awareness of the nervous system to the area more strongly. So what you do is you just rub right where the adrenals are, and you see if the person goes weak. And then you retest them. I will tell you, most of the cases just show up right there. Some cases show up with a GAS, hardly any lying down from standing up. Okay, it's just like you pick them up like that, and the patient gets better. And you can look, by the way, in a symptom survey where adrenal stress is, it's going to show up under the adrenal. Where's the adrenal one on the symptom survey?
7.
It's 7 something. That's where the adrenal show up, but it also shows up under blood sugar. It also shows up under male hormone, just so that you know, because it backs all those things up. So that's how you go with the adrenals. And then Ragland's test. We all know how to do this. We learned it in the beginning. You take 3 blood pressure readings, sitting, supine, and standing. The standing systolic should be 10 to 20 points higher than supine. Examples, supine to standing. A normal response is your blood pressure goes up. If it doesn't go up, you've got hypoadrenia. And then basically you do the same thing. Adrenaline, desiccated adrenal, adrenal complex, and energetic. Like I will tell you, I almost always use Adrenalin. I can tell you from being a practitioner, one of the reasons why I use Adrenalin almost always is that I've used other adrenal supplements and they work for a little while and then they stop working. What do I mean by stop working? It doesn't test right, and then also the person gets worse. I can tell you Adrenalin, they get better and stay better. There you go. Also, it's what Dr. Lee made to feed the adrenals. I mean, yes, we use a little bit of herbs, but we're meant to be fed by food, not by herbs or homeopathics. That's just my philosophy, and I've seen it kind of play out. Okay. So what's the Adrenopause nutritional strategy? An anti-inflammatory, excuse me, low antigen diet. Page diet for everybody. If you want, we have a page course. You can just go on to our Facebook page, which is Sheehan Natural Health Improvement Center. It's listed under standard process in a new clinical reference guide. I don't think it's listed as a page diet. I think it's called a beginning diet. What's it called? Standard. I don't know. They call it something else now, I think. But it's the page diet developed by Dr. Page. And we have the page course. We go over it in depth and it's free. It's on our Facebook page. Make sure you get sufficient protein, at least 0.8 grams per kilogram at the very minimum, and 1 gram per pound to gain muscle. As we age, we get less efficient at using our protein. We use more protein and we need more protein as we age rather than less. Eating less accelerates muscle loss. As we age, we should all be eating more protein, especially animal protein. Remember, plants are not efficient. And so we have poor efficiency as we age, and we make it more efficient if we go with a plant-based diet. That's just fact. Sorry. And then we need to weight lift. Okay, people say weight-bearing exercise. Walking is weight-bearing. Walking will not put on muscle unless you are completely deconditioned. No intermittent fasting, as this stresses the HPA thyroid axis. Cortisol drives T3 into reverse T3 and thus suppresses thyroid function. This is very, very important. I'm going to go over a couple case studies. A couple of them had very depleted pregnenolone and DHEA, and guess what they were doing in an effort to lose weight? Intermittent fasting. Intermittent fasting, basically, in the first 30 minutes when you wake up, you have what's called the cortisol awakening response, the CAR. 75% of your cortisol is produced in the first half hour of when you wake up. What stops its production and brings it down is eating. So if you want somebody to have high cortisol levels, tell them not to eat. Now, in someone that is 300 pounds and they're just diabetic and they just eat garbage all the time, okay, you can tell them that intermittent fast, it'll still make them healthier than unhealthy. Although I do have a person that just came in and he was obese and he went and did this and he had huge amounts of inflammation. One of the problems that we have with intermittent fasting is that, it's like we want to teach people how to eat for the long term. Anything that's not outside the norm of what we would normally do, we kind of revert to. And so you want to teach a person how to eat. And cortisol will drive T3 into reverse T3, and reverse T3 is kind of like the evil brother or sister, and whatever you want to say, of T3. In other words, T3 is the active thyroid hormone. Reverse T3 actually shuts down the metabolism. You do not want to shut down your metabolism. As human beings, we screw something up and then we want to do something drastic instead of something just normal. Like, hey, how about if we eat right and exercise and take the right supplements since it's not in our food? Like genius, right? But instead they're like, okay, well, what we're going to do is we ate like crap like this and we're going to stop eating for like a week or something like that. Or I'm going to stop eating breakfast. By the way, this person that had done that, he was doing one meal a day. And I'm like, all right, well, how much coffee do you drink? He's like, oh, I drink 5 cups of coffee to get through me today. And then I just go with one meal. He's like, I don't feel bad. I lost 20 pounds. His inflammatory numbers were through the roof. And he's already got cardiovascular risk factors. I'm like, dude, you got to learn how to eat. Let's just teach you how to eat. Go for a walk in the morning. You'll be vastly better in 4 months. Anyway, but I've seen this repetitively. It's 12 hours intermittent fasting from dinner to breakfast. I mean, most people don't need to eat during the night unless they got a little hypoglycemia. If they have hypoglycemia, look at the adrenals and B vitamins. We'll go over a case study. I wouldn't call that intermittent fasting. By the way, Laura has pointed out, and we've seen this. So why do you not want to do intermittent fasting? You want to stay away from screwing up your patients and jacking up the cortisol levels. If you want to skip dinner, that doesn't jack up your cortisol levels. You can do that. Okay, that will help. Most people don't want to skip dinner because it's a social meal. Okay, so no intermittent fasting. Protein in each meal, but no protein drinks for breakfast. Why do I tell people not to have protein for breakfast? I did a study in my office. I used to have a weight loss plan. I don't know, we had 20, 30 women did it. And we had a caliper method of checking body fat. And we checked 12 sites. It wasn't 3 or 4 sites or 6 sites. It was 12 sites. It was very, very accurate. And Group A drank their breakfast, had a protein shake. Group B ate their breakfast, protein. Group B lost fat and gained muscle. Group A lost a little bit of weight, didn't gain muscle, something like that. But it was dramatic. And I'm like, if I'm dealing with people, I should just tell them. So many people say, well, it doesn't fit my lifestyle. And I'm like, you might want to change your lifestyle, you know, just learn to eat right. So, fixed digestion and food sensitivities. So we go over this again and again. This is in the NBChem course for Yulin. Fixed digestion and food sensitivities, key area number one. Fixed insulin sensitivity, that's key area number two. And handle the infection, key area number three. That's how you handle Adrenopause, the best that you can do. The goal is to support the hypothalamus pituitary adrenal thyroid axis and adrenals, boost the pregnenolone and DHEA production. Supplements, Adrenamin, desiccated adrenals, Simplex F and M, Cataplex B or B core. I'm going to go over a couple case studies. I've used a lot of Adrenamin. I don't use that much desiccated adrenal or Simplex F or M. I'm not against them. I have a thing though, I'm kind of a little bit of a minimalist in my office, and the more supplements that you put a patient on, one, the more dependent you make them. Two, the less that they learn that they have to eat right. And three, the shorter time that you're going to be treating this patient. And let's just admit it, if you don't treat them for long enough, they don't get better. That's the reason why we try to do a minimalistic way of treating people. But you can look at what they do. Okay, Adrenamin, it's got B6 and vitamin C. It's got basically Cataplex G, C, and adrenotrophin for the HPA-T axis and pregnenolone, 3 tablets a day. By the way, if you want to look clinical pearl, first of all, we muscle test. Just muscle test how many they need. If you don't muscle test, for those other people that are taking this course, you can say, on a scale of 1 to 10, what's your stress level? If they say a 10, they're getting 9. If they say it's 20, their stress level is 20, you give them 15. Yes, you can do it that easy. If they say their stress level is like a 1 or 2, 3 a day. If they say it's a 5, 6 a day. Common sense, right? Okay. You got desiccated adrenal, which is a glandular boost, 1 to 2 tablets per day. You could do more once again with muscle testing. These are just suggestions if you weren't going to muscle test, by the way. I've seen it before. If you're low cortisol, desiccated adrenal might be something nice in addition to add to adrenaline because that's supposed to increase cortisol production. Excuse me. Simplex F and M. Remember to muscle test these. Lots of women need Simplex M to work on their male side. I have not seen that lots of men test for Simplex F, but that's for endocrine balance. 3 tablets per day. Muscle test, they might need 6 or 9. And there's Cataplex B and B core. That's got B5 for pregnenolone synthesis, 2 to 3 tablets per day. Once again, I muscle test. I will show you the person. We're going to go over a case study, and she tested for 15 Cataplex B, and within a week, hormonal problems left, and she's like, I'm not going back to that doctor. Anyway. So, Adrenopause nutritional strategy. Once again, stabilize the HPA-T axis and enhance resilience. Supplements, ashwagandha complex, rhodiola ginseng, and licorice high grade. I would say ashwagandha tends to be more calming. They can take it before bed. Or you can take, what's it, ashwagandha forte now. There's also rhodiola ginseng, especially for women. Licorice high grade, one of the things with this, they always caution you, if you increase your blood pressure, blah, 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 discontinue or something like that. I will tell you when I started my adrenal burnout, I listened to this doctor after I got better, and he said, you know what you got to do? You got to be vegetarian. That's what you got to do. And you've got to stop working out. And I was like, okay, doctor, you must know more than me. And all of a sudden, I couldn't sleep. And so I took tons of Cataplex B, and I would take like a tablespoon of licorice. Helped me sleep, but probably should have fixed those lifestyle factors like eating protein. Anyway, but licorice, what it does, it doubles the half-life of cortisol, if I remember the stat correctly. So licorice is really good for someone who needs more cortisol. Remember that. So lifestyle, 7 to 9 hours per night. Stress, non-sleep deep rest, NSDR, as proposed by Andrew Huberman, otherwise known as Yoga Nidra. Sometimes I have trouble sleeping. I'll put on, her name is Ali Boothroyd. Once again, do not know her, but Ali is awesome. I have said so many times, God bless Ali, because man, she puts me to sleep like that. Not in a bad way. I still do a lot of meditation. Yoga, and mindfulness. Always try to practice mindfulness. These all calm the HbA axis. Exercise 30 minutes per day, 4 to 5 times per week, which boosts pregnenolone and DHEA. My program, we try to walk a mile in the morning. We hike on the weekends, and usually I try to lift weights 3 to 4 days a week. Not like I used to. I was a crazy man. I'm less crazy now. All right. So integration, next steps. Strategy, calm the HbA axis with diet and lifestyle. Add supplements for the 6 to 12 weeks. Monitoring, retest pregnenolone, DHEAS, cortisol if you want after 3 months, or you can order it on blood test. Like I said, usually just blood tests, because basically it cuts the number of labs that they need in half and their cost in half. Advanced option, bioidentical pregnenolone or DHEA if needed, offer natural support. So what do we use? Bioidentical pregnenolone we get through DC Labs. It's just a cheap pregnenolone. They come in 10 milligram pills, and usually people test for between 1 and 9 per day. I've done studies on it. It will barely move the dial. It'll barely raise your blood levels. That's all that people need. Okay, and I'll show you. I have a patient that she shows me how she takes it. It's very easy how she takes it. By the way, pregnenolone is another hormone we use a lot. DHEA we use very much less. Women, I would not go over 5 milligrams because it does tend to increase their androgens and makes them grow beards. No, it doesn't make them grow a beard. What it does is it can increase their androgens. They don't feel bad, they feel good, but you don't want to show them something high on their blood tests and scare them. That's the reason why. I had a patient that came in, she's awesome, and she followed everything, and she went on 5 milligrams of DHEA, and actually her testosterone went up high. How high? Not very high. But I said, why don't you just cut back for right now? I don't think you need it. We gave it to her because she had a life-threatening UTI, and her doctor said it was from hormones, and she tested for DHEA. Fix it, better. Men can take usually 25 to 100 milligrams per day if they test for it. We muscle test for it. I take that one on and off. I usually take between 12 and 50 milligrams per day. That will boost androgen levels slightly in a male, maybe 10% or something like that. But that's what you need if you're really, really burned out. Okay? Listen, sometimes you need a little bit of boost. If you test for it, just go ahead and do it. It's not a long-term thing. And those hormones are so far upstream, they're not going to throw off the hormone production that much, and they're not going to disable your body's ability to make it either. Okay? But when in doubt, muscle test. So what do we do on Monday morning? You test everybody, you pulse them, test the polarity and their GAS. Do it on everybody and apply it just like I said, you will get much better results and the patients will be happier. One of the reasons why I was like, I got to teach this, I have so many women that are like, I need my Adrenalin. I say that. I'm like, I'm a happier person if I take Adrenalin. You know what? I'm not going off it. My wife has said sometimes, oh, I don't think you need it anymore. I'm like, yeah, put me under some stress and see if I need it. So I'm a better person with Adrenalin, right? When someone says, I don't want to stop taking that, that's when you know it works. Okay. Pulse the adrenals to 10. If you're over age 30, most people need some support for the adrenals and or heart. Remember this, okay? From what I have seen, I would say 80% of the people need either adrenal or heart support. They might need other things, but that's something that if you don't handle, they don't get better. I had one case come in just recently from another functional medicine practitioner that is like totally against muscle testing. So I said, that's exactly what I'm going to do. Because she was on like 15 different supplements, and these were expensive. And she had, what was it? Myalgia rheumatica, where basically her arms and her limbs hurt so much to move, she had to lift her arm up to put it in position. It was extreme, and she was on prednisone. Right there, if she needs prednisone, that means she's an adrenal case. So I muscle tested her. And she did not go weak on the polarity. Tridrenmin did not go weak. I put Cardio Plus on there. She went weak. And she also tested, she was blocked from her gut flora reflex point. By the way, that's another course if you want us to teach. We have some accessory points that we use from other techniques, but she basically needed to restore her gut and take a multiple for heart cardio plus. And she tested for 15 cardio plus, 6 prosymbiotic. Next week comes in after having polymyalgia rheumatica for 4 or 5 months. I said, how on a scale of 1 to 10, how bad are the arms today? She goes, 0. I go, a week, you have a debilitating autoimmune disease and you're better. Well, I said, is it a good day? And she goes, yeah, it's a good day. So next week came in. I said, how are they today? And she goes, 0. I said, so another good day. And she goes, well, it seems like the pain's gone. So now we're going on 3 or 4 weeks and she's like, the pain's gone. And then I tested on all the other supplements from the other functional medicine practitioner, and they all blocked her. So what was the big thing I missed? She needed Cardio Plus. And so I said, I'm sorry, I don't like to interfere with other doctors. And she goes, well, if I don't need them, I don't need them. And I'm like, yeah, and probably saving her, I don't know, $500 a month. All right, so let's do some case studies. So this one isn't really an adrenopause, believe it or not. So let's go over this case first. This is the reason why you remember in the beginning I said you want to test the people and do it right. His doctors didn't. So he was flipped out when he came in because he had a heart arrhythmia. And so the doctor said to him, well, you know what we're going to do for you? We are going to give you radioactive dye and then we're going to check your heart function. Well, it's radioactive iodine. And that's one of the reasons in the Sheehan panel we run the thyroid antibodies. Sorry, that was itches. Because if you have positive thyroid antibodies, you really have to watch it with iodine, especially in more synthetic iodine, like iodine that doesn't occur naturally in nature. Like we have seen that some cases of Hashimoto's can handle a little bit of the iodine found in organically bound minerals or Minchex or Mintran or trace minerals B12. But anything more compact, like some of the Lugol's or anything like that, it tends to be a little bit much for them and it overpowers them. And so they basically injected into him. And then he developed hyperthyroidism because he had a thyroid storm. And then he had really bad arrhythmia. And so the medical doctor's solution was, we're going to put you on anticoagulants, something to cause hypothyroid, and something to regulate your heart rhythm. So he's on these 3 drugs and he's flipped out. He's like, well, what can I do about it? Well, he came in and he quickly got better, but his doctors refused to take him off the meds. And he starts peeing blood. And he's like, I need help. And I was like, when I retested him, he was now hypothyroid, not hyper. The problem is when you treat them properly with nutrition, they get better so quickly. The doctors don't expect you to. I don't know exactly what they're thinking, but I think they assume that you're not going to get better as quick or you're not going to get better at all. Well, this guy got better, and all of a sudden he's hypothyroid. But his doctor's like, all right, now you need to keep on this medication to keep you hypothyroid. This one for your heart arrhythmia because you're, they didn't know why. And I'm like, well, it's because you got a thyroid problem. I said, you got to go see another doctor because I can't take you off meds. And his wife was going, well, what do I do? And I said, you have to go to another doctor, get him off the meds. Well, what do I do? You got to go to your doctor, get him off the meds because they're going to kill him. And he starts peeing blood. And I was like, if you go to lift something and you start peeing blood, you can be bleeding from other places. And so finally, they said, well, I'm going to go see this natural doctor. Well, the natural doctor, his big thing is put everybody on testosterone. So I said, let's check your hormones before. And so we gave him these. And as you see, it's high testosterone. But look at that estradiol and his total estrogens. His total estrogens were 3 times what they should be. What does this? Laura, what do you say to all this stuff with
Inflammation.
Inflammation. He was inflamed. I mean, he was on these drugs that were causing hypothyroidism, so he was getting inflammation. So that's the long and the short of him. So he went to this other doctor. The doctor said, stop taking all your medication, take testosterone instead. And then he said, I'm not taking testosterone. I'm just going to stop these medications. And now he's actually just taking one of them called Sotalol, which is, I think that's how you pronounce it, which basically regulates his heart rhythm. Because if he doesn't, now, I don't know whether it's because of the damage that it caused. I don't know what exactly did it, but he knows if he doesn't take that every couple of weeks, He'll get a heart arrhythmia and he'll be tired. And I'm like, listen, honestly, if you go from three really damaging meds to one, and I think he only takes half a dosage, that's a win. And so he's very happy right now. But anyway, that's his case. I just wanted to show you when we started doing blood testing, most men did not have a testosterone deficiency, and most women do not have an estrogen deficiency. They do have other things, especially inflammation and adrenopause. A lot of them, in fact, almost all of them. So he's much better now. I see him every couple months now. And basically, I have to put him on very minimal programming because he's still a little hypothyroid. He's on, I think, AF beta food, B12 2000 from Biotics, because pretty much all cases that are Hashimoto's hypothyroidism, they're going to run into a B12 and B9 deficiency. But that's for another course. I think he might take a couple Cardio Plus or Adrenal or something like that. But that's it. And he's very happy now. And now he's like, I'm going to go to you and get your blood test before I go to the doctor. That happens a lot. We order the blood test because they won't order full panels. I'll circle what's wrong, even write what's wrong, and be like, hey, da 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 da, so they can go to their doctor. So that's case study number one. That's a more, I'm not sure which hormone panel. This is one of our hormone panels through Avexia.
The basic, I think.
That might be basic, yeah. This is, oh, another case. We talk about medical wreckage all the time. I hope no medical doctors listen to us, but it's like, they are, they are. I mean, I don't know what to say about it. So this is JV. So she came in, I don't remember what she came in for. I think she wanted to lose weight during COVID. And she got better. Well, she was on a program where I was seeing her every 3 or 4 months, and she was very happy. She's around 50. And what happened was years ago, her doctor said, hey, you've got PMS or whatever it was. Let's put you on birth control. So she went on birth control. And then in between her visits to me, her doctor said, you know what? Let's get you off birth control and just put you on hormone replacement. I said, did they test you? And she goes, no. I was like, they didn't test you and they put you on hormones. I'm like, oh my gosh, why would somebody not test you if they're going to put you on exogenous hormones? Anyway, so we did. So what happened was the reason why was because after she went on the hormones, her left leg blew up. She never had the symptom before and she had trouble walking. I was like, that ain't good. And so she stopped taking HRT and I tested her to handle it. And what I found is she needed 15 cataplex B per day. That's another point. There's a point for B vitamins underneath the nose that you can pulse. That's another extra point when people need B vitamins that came up. And she took that, and within a week, her leg swelling went down and she felt better. A couple weeks later, we tested her blood levels, and this is what they look like. Like I said, all these women in menopause, they don't necessarily have low estrogen. If you look, I mean, her estrogens aren't high, okay? But if you look at her estrone is higher than it should be in menopause, you know? But if you look here, look at her progesterone, 0.1. Progesterone is downstream from pregnenolone. And there's my cursor. And then her pregnenolone is clinical reference range low. Her DHEA wasn't crazy low, but it was on the low side. So what did she test for? I think she takes between 3 and 6 Drenmin, 9 cataplex B. I think she takes another couple little supplements here and there. But she's very happy now. And what I did was I explained to her that basically she was in adrenopause since her 30s. Her doctor said, hey, we're not going to handle this. Instead, we're going to put you on birth control to get rid of her symptoms. It did, but it didn't fix the adrenopause. And so she went off the birth control and they just basically put her on hormone replacement without testing her. And then I was like, well, we got to handle this situation. And so what we did is we just did what the muscle testing said, which was cataplex B, Adrenmin, and there was a couple other things. I think maybe some AF beta food or something like that. And she's very happy. When your adrenals get pooped out in adrenopause, and then you go through menopause, the hormonal shift goes from the ovaries to the adrenals. But if the adrenals are tired out, you put on 10 to 15 pounds of fat because adipose tissue is an accessory hormone producer, especially in menopause. And so that's the reason why it happened. I said, listen, you can try really, really hard to lose this weight, or else we can work to rebuild you and just have a happy life because you're happy now. She's like, yeah, I'm happy again. I feel great. And I said, just understand that this is kind of your body going through a change. People don't like to hear the truth, but that was the truth with her. You know, it's always less stressful to be truthful. Anyway, might be momentary discontent. Anyway, so that was her. She's doing great now. This is AM. Once again, yo-yo dieter destroyed her adrenals, and she was coming in because she had some upper back and neck pain. And she'd be like, I did this great diet. And I was like, what'd you do? She goes, oh, I starved. I was like, no, no. But that's not what she said. But she went on one of these diets that was like, I don't know, 1,000 calories or something like that. And she kept on cycling them. And I was like, you can't do that to your body. And we always found that she needed, guess what? Adrenaline and thyroid complex. And that basically helped. And she goes, well, I want to have my hormones tested to check and see if I need more help. I was like, all right, let's test them. So what do we find? She's postmenopausal. She doesn't have low estrogen. Or she doesn't have like estrogen decrease. Okay. Maybe a little bit lower than she would have been if she was cycling. But her progesterone was almost non-existent. But she had functionally low DHEA and non-existent pregnenolone. And so right now she takes Drenamine, thyroid complex, and a couple other things, a little bit of this and that. But the other thing that we put her on is pregnenolone. And she came in one day and she would come in and off and on, she would get these hot flashes. That's what happens in menopause as your body kind of like recalibrates its HPA axis. And so she did something very common sense. When she has a hot flash, she takes 3 pregnenolone per day until they stop. That's it. And I was like, good, that's fine. And so that's what we did for her. Okay. And she's very, very happy with that. So that's one thing that I tell is because some people really don't want to be on hormones. And I'm like, I get it. She didn't want to be on them. She's like, I don't want hot flashes. So when I get hot flashes, I take the pregnenolone. That's it. This is a 62-year-old male. He came in after being in a coma from a nosocomial infection. He basically had some kind of problem, went into the hospital, get a hospital-acquired infection, and went into a coma. This was during COVID, and it was not from COVID, or so they say, or anything associated. And he came in and he said, well, I'm impotent. After you're in a coma for a couple months, things change. And so honestly, he has some weird looking insulin resistance marker, but he also doesn't totally follow, like he skips meals, he doesn't follow my diet right, all that kind of stuff. But he's like, I want my hormones checked. And I wanted to show you again that if you look, his testosterone is actually on the high side. But if you also look, his free testosterone is on the low side, which means he's got a lot of sex hormone binding globulin. But his DHEA was low, lab value low. But his estradiol was high. So what's his body doing? His body is taking that DHEA and converting it into the estrogens. And then if you have too much of, or I'm sorry, into testosterone, if you have too much testosterone, or if you're inflamed, which he was inflamed from chronic stress of being in a coma, he came in and he was still on a feeding tube and they took it out and he's like, I'm just going to start eating again. I was like, and he was told he wasn't supposed to eat. Well, he's fine now. But I was like, maybe you shouldn't be taking this supplement to raise your testosterone since you're taking a lot of it and turning it into estrogen. So he listened. And that's what happened when he stopped taking the testosterone booster from Costco, no less. His testosterone did come down. But we see that, not universally, but we see that with a lot of men. They actually don't have low testosterone, but through inflammation, they can be turning into estrogens, especially estradiol. But they might be in adrenopause. I think he takes Cardio Plus, maybe some Drenamine, maybe some Athletic B, something like that. Not a very big program. And he's happy too. He used to always be sick and all this stuff, and it's pretty much all better. This is another case. It's a former patient from about 10 years ago, and she came in because she read our newsletters, and I was talking about Hashimoto's. And she's like, I was just diagnosed with Hashimoto's. And I said, how are you handling this? She goes, well, I got on a good diet. I started exercising every day. And I think she said, and I do intermittent fasting where I skip breakfast. By the way, that person before that was having the hot flash that took pregnenolone, that was one of the things too. getting her to freaking eat breakfast. Oh my gosh. And the last person too, he also was like, I skip breakfast. Everybody's into this habit where they skip breakfast to cause inflammation and that throws off their hormones. I'm like, eat breakfast. Anyway, but this is CW's blood test. And as you can see, the way I found it with her was I was like, all right, treating Hashimoto, she's actually pretty relaxed otherwise. And I said, let's see if your adrenals show up. I stood her up and boom, she just blew out and she tested for Adrenochrome. So now she's on Adrenochrome and maybe a little bit of thyroid support. She's on like some fish oil and some turmeric, stuff like that. Okay. But that's about it. You can see here that her pregnenolone was just about non-existent. Her DHEA was lab value, no, not clinical, lab value low. Notice here that it flagged her FSH, follicle stimulating hormone. FSH and LH go up because those are two hormones that come from, I believe, it's the anterior pituitary that stimulate the ovaries to ovulate and maturation of the follicle, or yeah, something like that. Don't quote me on all my physiology, but basically, since she's in menopause, those hormones kind of go up. So just learn to recognize that. There's been some controversial stuff on to how to lower them or anything, but we're not going to get into that here. But for her, you know, handling the Hashimoto's was usually liver gallbladder support, getting off her gluten dairy 100%, supporting adrenals, and then her maybe a little bit of thyroid has done wonders for her. She's lost weight and she feels great. She feels fine. Yes, and she eats breakfast. And she loves our newsletters. So we went through those case studies pretty quick. It's real easy to see Adrenopause if you open your eyes, you look at their symptom survey, their muscle testing, and their blood testing. This one's a complete hormone panel that we have. And the other one, this one, is this that looks like more of a shortened one, right?
That, yeah, I think that's the basic. So those two
That's
you
the basic.
get when if you're signed up through our Evex.
Yeah, that's what we run. Yeah. We can also throw some cortisol. We might make another one for just for adrenal in there, and then that would be a cheap, easy tag on. The reason why I kind of hesitate just to look at adrenal function is because usually, like you guys asked, you said, what about hormones? And if you don't answer their questions on testosterone and estrogens, someone else is going to tell them. So many people, so many men say testosterone goes down as you age. And I'm like, not necessarily. It's actually not very common. And so many women say estrogen goes down as you age. And I'm like, not lab value low. I will say progesterone goes down, DHEA and pregnenolone definitely goes down. The other thing too is when we muscle test, usually DHEA sometimes tests well, sometimes not, but pregnenolone tests well very, very often. And Adrenochrome tests extremely well. I mean, it tests for just about, I mean, at least 50% of our patients. Like I said, our sales of Adrenochrome went up 400% last year once I figured this stuff out.
Those two that I put in there, those are our panels that we created. So if
Yeah.
for some reason you don't have access to them, then you can email me and I can email Avexia to get it added for you.
Yeah, it might mean that you're not signed up underneath us. So what source do we use? Supplement pregnenolone. Like I was saying before, we just use DC Labs, DEECEE Labs. You know why? It tests well. It's cheap. One of the things I've noticed with a lot of these supplement companies is that things are expensive. And if you can get something cheap and easy, that's what I use. And it tests very well. I know there's other ones out there, but usually other supplement companies are much more expensive. And it comes in 10 milligrams versus there's another company I know that make like 2.4 milligrams. And I don't see that that helps as much just eating mega doses. So just DC Labs, that's what we use. You can tell them I said hi. They don't know who I am. We run the same panel for male versus female, pretty much. Yeah. I like to see it because one of the reasons why you run a panel like this is it's like it gives you a lot of other analytes, but also it's cheaper to run a panel than to kind of cherry pick and put a couple of things in there. When would you order basic versus complete? I used to order the complete when I was looking at FSH and LSH more, and I'm like, you know what? I'm just going to look at these other things. It's cheaper, it's easier, and people understand them more. And so that's the reason why. I mean, what I can tell you, if they have high LH, theoretically, one of the things that will help bring it down is melatonin. Some people don't like melatonin. Anything that is like kind of controversial or not really easy to see. I kind of stay away from. So almost everybody, I use the basic hormonal panel, and we use that pretty often. As you can see, we've run on a bunch of patients. I will also tell you that a couple things here. If you're going to run blood tests, the blood tests are really good for using on men. On women, if they're cycling, I tend to go, the adrenal hormones don't tend to shift crazy with their cycle, but estrogens and progesterones do. And so you might want to look at a cycling female hormone panel from diagnostics. They have a cycling female hormonal profile. It's much more expensive. It's like $300 or $400 or something like that. And so it's much more expensive. And so I try to stay away from them, considering you're just going to look for the source of inflammation anyway. But I have a patient that comes in and she's having real hormonal issues. She eats right and she's put on like 60 pounds. And I know her family, her sister's the same way. But we're going to run a cycling hormonal profile. We had another friend that wanted to get it checked. She's a friend of ours. And she said, I want to see what my hormones are before I go into menopause. We run the salivary profiles a couple times a year. I don't know, maybe a dozen times a year or something like that. But the hormone profile, the blood test we run all the time. Once a woman is into menopause and they're not cycling, we just usually run blood tests. I mean, think about it and how the patient thinks about it. Are they going to understand blood tests better than urine tests and salivary tests? And what about when they bring it to their doctor? Is that doctor going to say, holy crap, this person really knows what they're doing? They know what they're doing blood tests. And they're going to say, why are they ordering this weird thing with their saliva and urine? You know, you always think about what's going to give you the most information, cheapest, and actually make you not weird. People don't want to see somebody that's weird. I'm weird enough. Anyway, people ask, they say, my doctor says it might be my hormones. My husband says it might be my hormones. My wife says it might be my hormones. Can I have my hormones checked? They just ask. One of my things, the way that I operate, I'm like, if you don't answer a person's question, well, that's one of the reasons why we put those newsletters out there, is because if we don't answer the person's questions, they're going to get their information from somebody else. And if it is not written, it doesn't exist.
Sometimes patients will come to you because they've got like a really severe hormonal problem. And if
Yeah.
you don't test their hormones up front, it just seems like something that really should be done for certain people,
You have,
especially if they know that it's a hormone issue.
yeah.
So I wish I had a better answer, but it's a clinical call.
Yeah, it's a clinical call. Because, I mean, what throws the hormones off? It's basically found in the basic blood chemistry in the Sheehan panel. That's what throws it off. That's why we run that first. But for some people that really want to know. All right, guys. Well, just get in touch with us if you have any questions, comments, and especially about what you want us to go over next. Okay? Thanks, guys.